you for joining me.
Got it. Well, welcome everyone to our CLABSI prevention webinar featuring Kathleen Bowman. Hopefully some of you were able to join us last week for the COTI presentation. It was really good information. And then Kathleen's going to come to Nebraska here in a couple weeks to visit us. So if you haven't gotten linked up to one of those and you're interested, holler at Amber or I think most of you probably already have, but if not, add your name, organization, and your role into the chat. Just helps us better understand who we're working with. And mute your lines if you're not talking, but if you do want to speak, please unmute and join the conversation. Otherwise, Kathleen uses the chat feature quite frequently. This is a recorded session, so these will become available once we get everything wrapped up. So without further ado, I'm going to hand off and thank you all. Have a good day.
Hi, everyone. I'm glad you were able to carve time out to join for the second in this series, really focusing on catheter and line infections. And we're going to talk about, needless to say, prevention and what are the evidence-based strategies around it. And Jessica, thanks for joining. I wanted to put my disclosures forth just to give you a background for those, some of you, I'm not sure how many attended the first one, but it's important, I guess, to understand where my area of expertise comes from. I've been a critical care nurse for over 41 years. My first CLABSI prevention initiative happened in 1996, yes. When I worked as a clinical nurse specialist in the medical intensive care units at Henry Ford Hospital in Detroit. And we started out with a rate of 6, and this was before chlorhexidine was recommended for cleaning. We, at that point, just had the process of every 4 days putting a new line in because that's what was recommended, and the guidelines came out and changed that. And they also said to fully cover and use a maximal barrier. So we made those changes. And a lot of the things I'm actually going to talk about because they're principles that have now been incorporated into bundles, and got our rate down from 6 to 1.9 before chlorhexidine came on board. So it's doable. Hence subject matter expert for the American Hospital Association. And I was part of the AHRQ work on reducing COTI and CLABSI in the ICUs that were having challenges around the United States. And I'm very excited to say, and I'm actually going to put this reference in the chat box, ahrq.org. Or no, it's .gov. And we just launched the toolkit from our experience with over 600 ICUs. And the data around COTI and CLABSI, the principles cross it, whether you're in the intensive care unit or outside the intensive care unit. And so I think this is a toolkit that you all can utilize. And it's broken up into 3 components. And I think I talked about this last time I was with you, the assess. So how do I assess my organization for what is missing and what is needed and where I'm at in this process? So it's a gap analysis kind of component, also helping you in developing action plans. And the second section is implementation, where it has a whole host of free webinars on the latest science, and I built a lot of those or updated them. So it's the latest evidence. And then my favorite section, which is the overcoming challenges. So how to address making sure the right catheter gets in, or that the physicians are part of the process, or bathing, the appropriate bathing. So a whole host of things that you can use as references, and they're all free. I also want to put my disclosures. In the past, I've been sponsored by these companies to speak. And so these are, but nothing necessarily pertaining I'm not sponsored for anything for this presentation. So I want to put that forth. We're going to do the objectives. I want to discuss the national trends that occurred during the pandemic and what was happening before the pandemic, so you can get an idea. And what I'm starting to see in the country is people are rebooting their processes and beginning to get back into some of this structure that they had prior to COVID. And really, how do we get back to the basics and resetting that culture and looking at the various detailed evidence-based practices that can help us. And hopefully, as we go through this presentation, one, you put any questions in the chat box. I'm going to be talking to you. We don't have actual polling. I'm going to do the old-fashioned kind where I put out a question and have you answer in the chat box. But also really do a mental gap analysis as we go through the various practices to see where there may be opportunities for you and your organization to improve on as a part of that journey. So bloodstream infections went up massively during COVID. This was data published by the government in the impact of COVID on healthcare acquired infections in 2020. Compared to 2019 data. So we had consistently seen a significant reduction in central line infections prior to COVID. And then you can see this steady rise that took place across the country. And so I think it's one of the things, and I don't know if have any of you seen increases in infection in CLABSI infections, or let's do the infections first, and then we'll do line utilization second. So I'm going to get you used to using that chat box. So has anybody seen increases in their CLABSI infections? Or is it mostly line utilization? Give you some chance to type here. Da, da, da. Because literally what happened in COVID was both. Line utilization, Bronstein thankfully is not, yay. Line utilization for Valerie, Amanda, line utilization, neither, okay. That's good. So line utilization, if that has increased, there is a greater chance that you could potentially have an infection. So we want to manage that as well. What were some of the things that we saw during COVID? Some of the practices that at least were documented in the literature as rationale for the increase. One was the shortage of PPE, and we didn't necessarily go in and out of the room as frequently. Also in places, and I suspect you guys experienced this as well. Did you get travelers as well as non-ICU clinicians in your intensive care units or in your emergency rooms? Yes, to travelers. Thanks, Becca. There was also reduced frequency of contact. There was less chlorhexidine bathing going on, alterations in line care. You can see pictures on the web of the lines dripping outside the room. I don't know if that was something that was done, but scrubbing the hub compliance, also just the frequency of auditing of what our practices were went down. In the larger centers where, and maybe this was done as well, prone positioning. It's very hard to keep the integrity of the dressings. Also line draws for blood cultures versus peripherals. And as I said, less rounding and things. So these were some of where that wasn't necessarily considered a huge priority. How many of you maintain collection of data on CLABSIs during the height of the pandemic? Because there was a time period when CMS said, you know, we're not going to have you collect data during this time period, but I'm wondering if you as an organization continue to do it. Lots of things relaxed or behind. Okay. Thanks, Valerie, for sharing that. And I would say I've only been in this position for 5 months, so you're not sure. Thanks. We did have a cohort 6 of the AHRQ project that I was telling you about that paused during the first component of the pandemic, that March to probably July or August. And there was a combination when we re-entered them back in, and I asked that question. Basically, it was half and half as to whether they maintained data collection on infections. We do know this problem is large, and it's not just in the intensive care unit. And for my infection control gang that's on the webinar, it is coming. Healthcare associated bloodstream infections related to all lines. How many have heard of that, including peripheral lines? So it's under review right now, as well as blood culture contamination, going from a 3% range down to a 1% range. So those are some of the components on the horizon that we're going to look at bloodstream infections related to all invasive devices that are indwelling in the patient, as well as a more stringent blood culture contamination rate. So keep that in the back of your mind. Don't worry about it just right now, but it's important. Forewarned is forearmed, as they say. There are now more CLABSIs occurring outside the ICU because the lines are extending beyond the intensive care unit and into the medical surgical environment as a part of it. And there is roughly a 2.3% increase or fold increase in mortality associated with a line infection. So it is a significant impact in the environment. So I showed this data last time for CAUTI, and here is this data for CLABSI related to excess mortality rate. What does it say? For every 1,000 in-hospital CLABSI cases, there are 150 excess deaths. So a lot more frequent mortality associated with this than CAUTI as a part of it. It's also, if you can see here, oops, let me go back here, clearly more expensive. You take a look at CAUTI here, about 14,000 was the average range. Here it is, CLABSI is about 48,000. So it's definitely a more costly, as well as to patient harm, as well as to the financial bottom line for our facilities. And so I wanted to bring this back to that concept of resetting that culture of safety within our work environments. As I said in the previous webinar, it may seem a strange principle to enunciate that the very first requirement in the hospital is to do the sick no harm. And really this concept or visualization of the frontline nurse and all of our roles as patient advocates should equal safety. And we need to see these actions not as technical steps that somebody needs me to do because they're going to audit me if I don't do them, but integrated as important interventions that I need to do as a professional registered nurse or a provider to prevent harm from taking place to my patient, and viewing it that way, in a different way. And so in moving in that direction, I wanted to share with you, like I did the last presentation, is moving closer to directly when an infection happens. And I know the infection is not as big of a case as utilization, but if you're having increased utilization, you may want to use something like this, not related to an infection, but related to increased utilization, to drill down in asking if these practices are taking place so we can prevent harm from occurring. And as I shared previously, what I did with the infection preventionist is I would ask them when they are 80% sure that it's likely going to be infection to call up to the unit wherever this patient is. So this type of huddle, immediate huddle, could be done very similar to us doing immediate huddles for falls. To find out exactly what's going on with these patients and creating an action plan. So those are all steps that have been utilized, and those tools are actually available as part of under the implementation section of the AHRQ website. So it's not just about these technical strategies, but it's about changing the culture in our environment for not putting the lines in if we can prevent it, the lines in the catheters, but also how can we get them out sooner to reduce the risk for our patients as a part of that journey. And so it's really creating that culture of safety. And as I talked about the last time, and I'm going to reiterate it here, is this our CAUTI and CLABSI permanent agenda items in multidisciplinary quality team meetings? So go ahead and put that in the chat box. Are they routine part of permanent agenda items? Whether it's at your multidisciplinary quality meetings that take place on a monthly basis, if you have something like that, Amanda, great. Does this data get back to our physician colleagues about utilization in their potential staff meetings? Or is the CMO represented on these committees so that that data, your quarterly board and med staff for utilization rates, that's awesome, to the providers as well, yay. Now, may I ask, are you also getting it to the front line? Because the frontline nurses engaged in this journey need to be a part of that communication with our providers about, do we still need this line? What's the line necessity component? Or what's the catheter component? Frontline some, but not so much. So hopefully that can change, because all the data really focuses on, they call it going to the Gemba, is literally going to where the work is. And that work is done at the unit level with frontline staff. So I would ask you to think about how that may be incorporated into your processes in that journey, because it then allows them to begin to take real ownership of this and not just having individuals in this oversight capacity. It's more of a ground up. And these individuals, us, serve as consultants to help make the right thing happen in that environment. So it's just a different way to look at it. Refreshing expectations on clinical practice and documentation, and helping the entire team understand. And one of the things, it's almost a kiss of death to a frontline staff, I'm just being real here, to say, because this is reported or we don't get reimbursed by CMS, that it's a government thing or a JACO thing. Because then they see it as a compliance measure and they don't see it as, this is what I own to prevent harm with my patient. So we need to reframe how we launch and sustain these initiatives outside of the external forces that are facilitating ensuring that these practices happen. And then, as I said, continue to measure and have data-driven solutions as part of this journey. All right, and so hence the data-driven. Especially with infections, and I know you're having more utilization than infections, but if infections come up, drilling down when, when the infection is showing up. Is it showing up early within the first 5 days, or is it showing up late? So you can differentiate between early and late infections, which are important, because if it's early on CLABSI, you're going to want to address providers and some of the components around it that I'm going to talk to you about. And if it's maintenance, then you're going to address some additional components as a part of it. And I will tell you on CLABSI, and you're going to have the reference here, but new guidelines just came out. There's SHE, which is the Society of Hospital, let me see if I get this, Hospital Epidemiology, and Infectious Disease Society of America, and the American APEC, the Association of Practitioners in Infection Control, I believe, if I get that right. And also the CDC was part of this. So we have new guidelines that were published in April of this year. And if you're interested, vent and non-vent pneumonia was just published this month by this same group. So again, taking stock in our environments on some of these fundamental care practices are an important component of rebooting and resetting our cultures after the challenges we've been through. All right, so let's look at some of the key evidence-based prevention strategies. And again, you're going to see this circle because it applies to not only the indwelling catheter, but it also applies to the central line catheters. Do I have a link? You know what? I don't have a link, but maybe one of the guys, can one of you take a look at that previous slide? This one? That's the reference. Yep. And see if you can go after the link online. Yep. Thanks.
I'll do.
Appreciate it. And so avoiding the catheter if possible, you're thinking, this one's going to be a toughie, especially if I need vasoactive drips or certain things. And I've got a guideline that I'm going to show you that I think is going to help with that. Then we're going to work on aseptic insertion. A big one here is maintaining awareness and proper care, and then prompt removal is important. So in the guidelines, not the new guidelines, but in the AHRQ tools, they talk about a two-tier system. And I mentioned this with CAUTI prevention as well. And what the first tier is to assess appropriateness and need for CVC, then select the appropriate site, ensure appropriate insertion, and then proper care and maintenance, and optimize prompt removal. Then it basically says, if those are not enough to get you to zero, then is there a way to incorporate the discussion in rounds or doing audit? Can we provide CVC utilization metrics back to the staff and the providers? And it sounds like some of you are already doing that. Is it an insertion problem, and do I need to monitor that component? And do I need to use a different catheter potentially if I've got a problem and I'm still having challenges with reducing my infections? And then this concept of doing a mini or a root cause analysis for every infection. So that's sort of like an overview, but we're going to dissect it a piece at a time. So let's start off with the BSI prevention bundle. First, remove and avoid unnecessary lines. And I'm going to talk to you about how we get there, how we prevent that from happening on avoiding the unnecessary lines to begin with. And then we'll talk about some strategies on removing. Hand hygiene. I'm curious, do you guys know how often staff should be washing their hands in a single shift. How many times they should be doing it. Go ahead and put a guess in the chat box. I've got some infection control souls here. 873. Way to go. Amanda, you're right. A heck of a lot more than they do. They're actually supposed to be doing it in a 12-hour shift 100 times. And they're doing it about 50. So needless to say, we have an opportunity there for all of our infection prevention, ensuring that they have a maximal barrier completely covering the patient's body. Alcoholic or chlorhexidine, alcohol-based chlorhexidine prep for the skin, which has an alcohol component to it for quick drying. And then in the new high level of evidence, subclavian preferred. So they removed avoid the femoral site and decided to go with target the subclavian. However, I crisscross this entire country and nobody puts subclavians in. They're all using IJs. Is that the lines you guys are seeing? Is pretty much internal jugulars? Oh, yay, Lisa. Are they using, I haven't seen a subclavian in years, Amanda. I see a lot of pics. Yeah. And are they using, I'm sure your PIC people are using ultrasound guided. Are your providers that are inserting subclavian or IJs using ultrasound guided? Yes, we use ultrasound. That's good to hear. So this was interesting. This was a study, 984 adult intensive care units in 632 hospitals. The bundle elements, all 5 of these elements with greater than 95% use had a 33% reduction, had the best level of reduction in infections. If they were compliant with at least one bundle element, they had the second best reduction. Less than 75%, no changes in rate seen. So it sort of gives you an idea of how powerful this bundle is in reducing early infections. So what are some essential practices with insertion? Before insertion, patient daily bathing with chlorhexidine, and we'll talk more about that. That is high level evidence, use of ultrasound guidance, high level of evidence, and use of an inclusive catheter kit or cart, which is moderate evidence. So what I'd like to ask is how many of you have an inclusive kit for the provider for inserting central lines or PIC lines? We do, great. Because the beauty about kits are they really, if they're designed correctly, they force function behavior. So literally how the provider is supposed to do it from start to finish literally goes in the order that best practice is. And what we found is we started with a cart. So by the way, this was in 1990. We had a cart and we realized that the cart wasn't enough. And so we created, and that was one of the strategies we used to bring our rate down. We actually created an all-inclusive kit. And we ultimately, in 2002, went house-wide with it. So we were working on this for quite a long time. So it's not just important to have a cart, it's really important to have a kit because the kit needs to be everywhere lines are inserted. So it's easy for the staff to get and make sure the provider delivers that insertion practice 100%. Oh, thank you, Amanda, you found it. Appreciate that. So here is something hopefully your PIC people are using, but this is something that can be taught to your providers, but also taught to your nursing staff so that they encourage the provider to use the right catheter at the right time for the right type of infusate. And what is exciting about this tool is it's a guideline, but it has these two wonderful diagrams that you can laminate. I used to be known as the laminating queen in my unit areas. But what this one, so this is for peripherally compatible infusate. So it has, here is the duration of the therapy. Here is the type of catheter that should be used if I have peripherally compatible infusate. And then the next one is if my infusate is not peripherally compatible, and I have duration of infusion here and type of catheter. So you don't see peripheral catheter used. You don't see peripheral IV guided. You see here, central, PIC, and then tunnel catheter for certain things. Now, where this process should probably be changed, and if you can manipulate it, that would be great. How many have heard of the new recommendation from both INS and also the Society of Critical Care Medicine's Surviving Sepsis campaign guidelines about vasopressors in peripheral lines? So is your emergency room putting vasopressors in peripheral lines? Are you aware? Yes. Basically, there is a recommendation now to, in the initial phase, I believe it's 6 to 8 hours, where the patient could potentially come off the vasopressor, that you could run it in a peripheral line. Now, my recommendation, based on all the data, is that in my perfect world, because that's where I live and I work really hard to get everybody else to hang out in my perfect world, I'd have ultrasound guided peripheral IV catheters inserted in the emergency room if I was going to do vasopressors. It just makes sense versus a small peripheral catheter, especially not in the hand. So, but then you also have to make sure that if it goes beyond that time, a line is inserted. And so do you have policies, Amanda and Valerie, related to the amount of time your vasoactive can run before a central line needs to go in? I think that's a really important, don't think so, but most of the time we are transferring those patients. We do not. So if you're transferring them, it's not a big thing, but I would, so Amanda, you're working on it now. I would make sure that you incorporate that, guys, so you don't have it extending beyond what is recommended in the literature. And at that point, you've got a window of time where you know the patient is not going in the right direction, that you can have a PIC placed if necessary, or a central line based on what is needed. So that leads me to, let me see if I've got the question coming up. Where is that question? Oh, the question disappeared. So I'm just going to ask it. Are your lines inserted? Is your PIC group on site, or are your lines inserted by a third party that comes in from the outside? On site, Amanda, thank you. What about the rest? So Lisa, you have both. Your CRNAs are inserting. We are CAH, so you have a third party on site. So it's really a mix, it sounds like. And so how long does it take so for those that have the third party, may I ask how long it takes from a call to getting the line in? 1 hour. Wow. Okay. So are they using any type of guidance like this type of tool, or is that decision being made before the third party is called? And by the way, guys, feel free to open your mic on this so that we can discuss this. So Lisa, your PIC team works with the provider, great, to make a decision. But is your PIC team using anything like this? Because what I'm finding across the country, so the decision's made before the call. So it is critical, Desiria, I don't know if I pronounced your name correctly, that some type of tool or guideline like this should be used by the clinician before they make the call. So your third party is putting in the right catheter for you. Whether it needs to be a midline or, and are these same providers putting in your midlines as well? Yes. Okay. So it is imperative, guys, because, you know, we're all thinking, oh, let's just put a midline in. Well, guess what? In a year and a half, they're going to be counted for bloodstream infections. So it really has a place based on duration and peripherally compatible infusate. So I'd really think about having some kind of chart available. Physician's orders, we call the PIC team, sometimes the PIC team nurse questions, depending on the diagnosis. That is great. So what I've started doing with clinicians across the country is empowering the PIC team, like your people have there, and also empowering the frontline nurse to say, hey, here are the guidelines. Maybe this is a better catheter before the physician orders it, so that they can order the correct catheter. So that sounds like it may be a process that has to be, that there is an opportunity to improve how that process happens in your organization by guidelines, using the guidelines to help drive that process. So line location, I'm glad, and we talked about this a bit, I am glad to see some are still seeing subclavians, but I would suspect a lot of you have more PIC. So I'm gonna say what I think, but I may be wrong. Are you having more PIC insertions than you are actual subclavian or IJs? Because I'm even seeing that in larger hospitals as well. Yeah. And is that because they're going to need the therapy for a long time, or is it because there isn't a provider, or the provider doesn't really, I'm just going to be frank, doesn't really want to do it, and so they say get the PIC team? So your CRNAs only do the PICs, you're not sure. Long-term antibiotic, okay. And long-term antibiotics are totally appropriate for that. And I take it you have CRNAs on site 24/7. The ones that have CRNAs inserting, yes, on site 24/7. Are your PIC teams 24/7? So you only use PIC team unless it's an emergency. Okay. And are all your PIC teams 24/7? Except for those that use the third party. Okay. So just to give you the data on this, there's a twofold risk of CLABSI using jugular versus subclavian. higher risk of CLABSI and thrombosis with femoral versus subclavian, which is why they put subclavian first. And guess what? If you do simulation training, subclavian is safe. Now, it doesn't sound like you guys have a lot of IJs. There is an IJ procedure that physicians can learn that doesn't go this way. It actually enters the IJ this way to make it easier for the dressing securement. So I just thought I'd let you know about that. Are any of your emergency room staff being taught ultrasound guided peripheral catheter insertion? Or do you have that technology available? Or is it only your PIC that have the ultrasound? No, not available. So there are at least 5 CRAs do US ultrasound peripheral, but not general nursing. Okay. Hopefully your PIC team will also do ultrasound peripheral as well. I'm hoping. Available, but not general nursing. Okay. One of the strategies that has been shown in the literature to be successful at reducing the utilization of central lines is more utilization of ultrasound guided peripheral. And in midlines, the infections are less, but there are more mechanical issues. There is no difference in DVT between PIC and midline, and there's no difference in infections between a centrally inserted versus a PIC line inserted versus a peripheral inserted. So that sort of gives you an idea. If you have infection issues, so are you, well, let me ask this question. Are your PIC people, is it a 2-person adventure? Is it a 1-person adventure? And what I mean by adventure, I mean staffing, 1 person. So does the nurse in the room, 2-person adventure, thank you, Valerie. Does the nurse in the room, is there a nurse in the room that goes through the central line insertion checklist to make sure sterility is managed as a part of this? Is that something recommended in your policy? I don't think so. So this is something that for PIC, for any peripheral or centrally inserted line, we use surgery nurse if possible as the second in the room. So you would hope that they maintain sterility. Now the nurse that's participating in this, the floor nurse or the ICU nurse, doesn't have to assist with the procedure. I mean, they can gather supplies and things like that. Timeout is done and nurse only stays if the patient is large or confused or the PIC team requests. If there's only 1 person in the room, then nobody's watching potential break in sterility. And that is really the purpose of the 2-person component and the purpose of the central line insertion checklist as a part of it, to make sure the sterile gowns, the mask, all of that is used, everything is set up appropriately. So do you guys have a checklist? You didn't know you'd be typing so much, huh? Well, you probably did if you attended. Needs to be revamped. Use it, but not used, but not sure they still use it. So this is something on the insertion side. I mean, I know you're not dealing with infections, it's more the utilization, but if you do, this would be something to look at. The observer shouldn't complete it. So what's happening in the larger hospitals, this has been incorporated into the EHR and the inserter actually fills it out versus the observer, which sort of defeats the purpose. And then hopefully we're doing audits for utilization, but I'll talk more about that. In the timeout section, there is, but could definitely be used better. So an opportunity. So what methods are you using to address utilization issues? And feel free to unmute yourself and share with the group what methods are being used to address length of time the catheter is in, and to ensure that the catheter is still appropriate or could be removed.
To be honest, Kathleen, we don't have a lot of infections, which is not an excuse, but sometimes, just like I talked kind of with our Cotty, sometimes I feel like we would get better buy-in or better attention to the matter if we had some
An
infection.
infection, yeah.
Yeah, that's terrible to say. But that's kind of where I have read our staff, and when we go through processes or talking about this on the agenda, you know, our utilization rates. So we don't do a whole lot right now.
So one, yeah,
plans.
Becca, one of the things to think about is taking those charts and doing an audit in your hospital, and just for everybody who has a line, seeing if that line is still appropriate.
Right. We do an IDT round every day.
Oh, you do? Okay, so that's one of the methods to assess
Yeah.
utilization, by the way.
So I plan to do that, use that list and talk through that with staff. And sometimes when they see it as well as hearing it, sometimes that's
It's
helpful.
a little more, yeah, it's more concrete.
Yep.
Well, and then they also have evidence to talk with the provider about the fact that the line needs to be switched to a different type, because the indication for why it went in is no longer there, I guess, would be the conversation. We have infections that just barely miss meeting criteria for NHSN reporting, but I still keep track. I'm in the same boat. If they're not reportable, people don't want to take them seriously. All right, so what I say to that, so do you follow, Amanda, do you follow those patients out to find out what their outcome is? How much longer length of stay they've got, even though it doesn't meet NHSN criteria? Because of those consequences. So you guys got a battle, there's no question. But I would definitely work on educating about peripherally compatible infusate, non-compatible infusate, what type of line, have those laminated so they're part of any kind of line discussion as a part of sharing your utilization data with your physician groups as well as frontline staff. So in some places, and I know EHR reminders weren't really out there for your catheters, so they may not for your urinary catheters. This is one of the strategies that's been being used. So there's a flag that it's still there. Handoff communication. So in shift to shift, report handoff that a line is there, multidisciplinary rounds. And it sounds like you guys are doing this in medical staff meetings, working on getting a vascular nurse on board that can help me track that. Oh, that'd be awesome, Amanda. And medical executive meetings and peer-to-peer communication, because all it takes is for you to have one official infection and you're going to be out of range because you don't have that because of the size of your facility. And so I think that's important to pay attention to. The other area is really after the insertion of the bundle. And that is how we dress the site, how we bathe it, how we access the site, what type of line we're using, and then appropriate staffing levels. And that really has to do with the care and maintenance of it. So is evaluating the inclusiveness of a central line dressing part of the nurse's shift assessment?
Yes.
Yes, okay. And if the dressing is flopping up a little on the corner, what is their usual behavior? Is it taping it down or changing the dressing? Valerie, yes. Should be changing the dressing, but we all know how that goes. Are we talking about what they should know, what they actually do? Probably taping it down. Understood, guys, but that's a practice change. And there's some strategies too, because one of the things about dressings, and I'm old enough to remember this, we actually had really sticky dressings at one point in my career. But guess what happened? Nurses ripped them off and we had skin injury. And so the companies backed off on the adhesiveness of the dressing. So they don't have the tactile strength to last that 7 days. So I'm going to provide some strategies for that. But first off, let's talk about what type of dressing. So what type of dressing are you currently using? Do you have, so share what type of CHG or no CHG? Do you have impregnated sponge? Do you have the CHG in the dressing or a regular Tegaderm, whatever comes in the kit? Well, Valerie, that would be a really good thing to dissect to find out what does come in that kit. So you have the CHG, Leah has the CHG gel Tegaderm. So what I wanted to do is share the data. So this was published a while ago, multi-center randomized controlled trial, 7 ICUs participated. They included all patients that required an arterial and central catheter for 48 hours or longer. So by the way, I also do this for arterial lines. Use of CHG dressing versus a standard dressing. So they used the disc, the BioPatch disc. They were already using the maximal sterile barrier, putting the subclavian as part of it. And then the other component to this research study is they looked at the difference between 3-day and 7-day dressing changes. And what happened when the dressing was changed because it was loose, soil, or damp in all the groups. And so what did the data show about the sponge? It basically showed that by using the sponge versus a regular Tegaderm type dressing like Opsite 3000 without a CHG sponge, their rate went from 1.3 per thousand catheter days down to 0.4 per thousand catheter days. So basically what that said is one major CLABSI for every 117 catheters was prevented. And so this really changed the game. And we moved to putting the disc, the CHG disc. And you can see here, small level of contact dermatitis with the patch. And I saw you mentioned you had some irritation from them lately. And there was no difference in site colonization between dressings automatically changed at 3 days or changed at 7 days, but they studied this further. And that's what I wanted to share with you. Dressing disruption. So it can be a major factor to catheter-related infections. So this was a secondary analysis of that randomized controlled trial. So they looked at about 1,400 patients looking at about 3,200 arterial or central venous catheters. And I want you to focus on this right here. 11,000 dressing changes and 67% were done before the planned date. So what impact did that have, this dressing disruption? Let's take a look. Number of dressing disruptions was related to an increased risk of colonization of the skin around the catheter at removal. Risk of infection increased threefold after the second dressing disruption, and it was tenfold at the final dressing disruption. So what the research is showing us is that multiple dressing disruptions, because they're not adhering well, can increase the bacterial bioburden underneath the dressing, which makes total sense to us. So before I go to that, I want to show you this. Let me just jump ahead. Oh, I must have it much later ahead. So keep that thought in mind about dressing disruptions, because I'm going to come to that in just a little bit to talk about how we can address that. So what then happened, and I saw Leah said there she used the CHG gel transparent dressing. And so a study was repeated. Let me go back here. 12 French ICUs with central lines expected to be longer than 48 hours. They compared three types of dressings: the regular or the CHG transparent film, so that it has the little patch of CHG in it. The transparent HP highly adherent. I don't know if I'd actually call it that, or the regular transparent. And they looked at all dressings at 3 and 7 days based on unit practice. And they also looked at colonization and infection rates. So they had 4,000 catheters, so pretty much the same as the other. And what they saw is when they used the CHG dressing, they had a rate go from 2.3 down to 0.9 per 1,000 catheter days. And the dressing change rate, you can see I had 14,000 dressings soiled. If somebody could close their microphone, because we're hearing background noise. You can see here dressing soiled, only 30% of them were intact, 30% were detached, 27% soiled, and 12.5% detached and soiled. And the most common ones, go figure, the IJ and the femoral. And so we now have a meta-analysis, use CHG dressings in all patients greater than 2 months of age, and it's a high level of evidence. So it clearly makes a difference. This is what's called a forest plot. Everything on this side favors a regular transparent. Everything on this side favors some form of CHG dressing. Now, what I have seen in the clinical environment is oftentimes the sutures make it difficult to put this, if you're using the biopatch. And Valerie, maybe you can share if you've evaluated your experience with that, if they've actually got the CHG disc on correctly. And so that's something, if you're using the biopatch, so both of them work. But if you're using the biopatch, you have to make sure that it's put on correctly as a part of it. So that may be occurring in audits or things as a part of that journey. And significantly, I mean, there's no difference in adverse events. So this was an independent study done in the UK on dressing disruption, how much it actually occurs and what impact that has on nursing workload and expenses with 4 different dressings and how long they actually stay on. So they had 590, this is one of my favorite studies, almost 600 CVCs with 1,200 dressing changes. These guys were trained on evidence-based practice dressing changes for each of the dressings. So in phase 1 of this study, they had the standard dressing, sterile, transparent, Opsite 3000, 3M Tegaderm. Phase 2, 3M Tegaderm IV Advanced. So this was the more secure dressing with an integrated border around the dressing. And then phase 3 was a dressing called Sorbiview. It was an integrated 2-piece dressing, one part with a site-wise border and then one port with a bridge. And I'm not exactly sure what you all use, but what they found, and I wanted to point this out, is you can take a look here. All the transparent type dressings only lasted about 2 days, 48 hours. The best dressing lasted 3.5 to 4 days. So basically what that's saying is none of the dressings, unless we do something different, last long enough. So the mean time to change a dressing was about 13 minutes, but the cost ranged anywhere from $3 to $8. So what am I going to do to improve this? Well, there is data out there, and it's actually, it just was recommended in a editorial that came across about improving dressing management, is to use a more adhesive prep. Because right now in most of our dressing kits, they have skin prep, which actually removes the oils on the skin, but it's not an actual adhesive. So it makes it more tacky, but it's not an actual adhesive. So they recommended the use of something called gum mastic. And some of you may be familiar with the trade name of it, and that is Mastisol. And so what they did is they painted, after they finished everything, they painted the Mastisol before they put the dressing down. And they went from a 61% change on day 1 to day 2 to 13% after the intervention. So you can see they had a boatload less detached and number of dressing changes. Now, what I also recommend that if you do move in that direction, that you also on your dressing kit put a removal like Detach-All, so that the staff, when they're changing the dressing, is actually removing the adhesive so they don't injure the skin. So how many of your organizations have a dressing kit that includes all the appropriate components? Yes, awesome. So there's actually some good human factor engineering. This was a study published in 2017, designing the kit to force function, use of the evidence, and also the correct procedure. And that there also be tabs to open the kit, visibility of flaps, and they had pockets in order to sequence the activity. And I'm going to show you this. I don't know if any of you have ever seen something like this. This is the sterile component. They also have an unsterile component that flips over. So when you open it, the unsterile shows up first. It has hand hygiene in there. And if you do the Detach-All and the Mastisol, you can incorporate that in the process. So it takes you through all the steps to remove the dressing. And then it takes you through all the exact steps to put the dressing on appropriately. So this was a 29-month prospective trial, 95 nurses, 151 patients, 126 observations pre. So when they did not have a pocket-based dressing kit, and 90 observations post-intervention of the kit. And if you guys take a look here, they actually had a significant decrease in line infections from 2.21 down to 0. 10-fold decrease, better adherence, and there was 44% reduction in missing steps. In other words, they had better procedure adherence by force functioning with these pockets. And by the way, those pockets were invented by nursing. All right, what else is there? What type of bathing is performed on patients with central lines in your facility? Can you tell me whether it's 1, soap and water bath, 2, CHG impregnated cloth bath, 3, CHG poured onto cloth bath, or CHG poured into water bath? So you could just put 1, 2, 3, or 4 in there. 1, 2. Okay, what else? Come on, guys. So these are all the things, if you've got longer utilization, you need to make sure either the line goes out or these care practices are put in. So let's look at the science. As I said, I believe I mentioned this in the previous, there is an independent research that shows soap and tap water bathing is an independent predictor of a bloodstream infection. So we have to change that. And part of that journey, and I shared the problems with the basin and the tap water in the last presentation. Here is the data on CHG bathing and how it evolved. So literally how it started is we were doing 4% CHG for showers for pre-op surgical prep. And there was a Cochrane collaboration review that compared it to soap and water showers to see reduction in surgical site infections, and they didn't find a difference, even though we know CHG is a good molecule for cleansing and reducing bacterial load. And they found out 2 things. 1, the CHG should stay on the skin. And the second is that cotton, that CHG molecule binds to cotton fiber. So into the marketplace came an impregnated CHG cloth that was used for pre-op. And there was a doc in Chicago that said, I have a big VRE bug fest in my 2 medical ICUs. I'm gonna take a look at soap and water bathing, CHG basinless cloth bath, and non-medicated basinless cloth bath, and figure out what happens to my VRE load on these patients. And what they found, you can see right here, is the top load was soap and water. No change in the VRE load. You did have a reduction with a non-impregnated, so non-medicated cloth bath. You did have a reduction, but it wasn't statistically significant. However, you saw the load for VRE just drop right off, and you saw it sustained out to this area. And what they were able to show is they went from 26 new colonizations of VRE per 1,000 patient days down to 9. So they really dropped the load in the environment. And what they found is when they dropped the load on the environment, they dropped the load on the staff's hands, and they also dropped the load in the environment itself. And so then there was a series of randomized control, or not randomized controlled trials, but before and after trials that looked at CHG bathing for reducing CLABSI. This first group was with pouring the CHG in the water. The second group was with the impregnated cloth, and both did show statistical significance. But remember, this was before and after trials. Then we move to clustered randomized trials. So by the way, in this type of science, this is as high as you can get, because I can't blind somebody to a bath. So I can't do a double-blind placebo randomized controlled trial. So what I do is I cluster them, match the organizations, but have bathing done in one organization and a different bathing done in another. So this was 9 ICUs and a bone marrow transplant unit. They randomly assigned close to 8,000 patients. And by the way, because of the previous research, they didn't compare tap water bathing because they already found it put the patient at risk. So they did no rinse CHG washcloths in comparison to a non-medicated no rinse bath cloth. And what did they find? A 23% reduction in overall multi-drug resistant organisms, a 28% reduction in bloodstream infections, 50% of that was gram positive. And because they included a transplant unit, they had a 90% reduction in fungal. So pretty powerful. Then there was an even larger study, 75,000 patients, 16 states, 160 intensive care units. Again, clustered randomized trial. They were going off, could we reduce MRSA and MDROs? So they had 3 protocols that they did. They swabbed the nose, plated it. If it came back positive for MRSA, they isolated the patient. That was the first one. The second one, swab the nose, plate it, isolate them, but do a CHG bath. And this was done in the ICU until discharge from the ICU, and mupirocin or I think it's Bactroban. I think, yeah. So mupirocin in the nose for 5 days. And the last one was no swab, no isolate, mupirocin in the nose for 5 days, and CHG bathing. And that was called universal decolonization. And it was the universal decolonization that resulted in a 37% reduction in MRSA infections and a 44% reduction for CLABSIs from all pathogens. So by the way, this is what launched the chlorhexidine bathing across the United States in intensive care units. Now, what they didn't adopt was the mupirocin because the antibiotic resistance. So they did partial of the universal decolonization. Now, this study was repeated in 53 hospitals in 14 states in the med-surg, in the general medical surgical population, where they compared non-medicated disposable cloth or showering to decolonization with the 2% CHG cloth and the mupirocin. They did a 12-month baseline, 2-month phase in, and a 21-month intervention. Doing this targeted decolonization and targeted mupirocin for MRSA carriers didn't significantly reduce multi-drug resistant organisms across the board. But what they did show was in those patients in the medical surgical environment that did have lines, they had a 32% reduction in all-cause bacteremia and a 32% greater reduction in MRSA and VRE. So this helps solidify that if I have a line, then it needs to be done in the med-surg environment as well. So that sort of gives you an idea. And this is the most recent meta-analysis. And it clearly shows a highly statistical impact of CHG bathing on CLABSI as a part of it. So when you look at this, it works upstream. The patient sheds the pathogen, so I start decolonizing. Then I do all of this rest as a part of it. But if I don't start with the patient shedding the pathogens and managing that correctly, I'm challenged as a part of it. So does the method of how I do the CHG bathing make a difference? And this study, besides the fact that all the large prospective clustered randomized trials use the impregnated cloth, this one was a blinded 2-center assessment of the concentration of CHG in the skin based on the method that was used. So method A, which is in black, was the impregnated cloth. Method B, this lighter gray, was 4% CHG poured on a non-medicated cloth. And the fourth one was pouring the CHG liquid on a cotton washcloth in the water. And you can see the impregnated cloth at time of application, as well as 6 hours later after cleaning, showed significantly higher concentrations of CHG. So the method in which you do the bathing makes a difference as well as a part of this journey. So what area of the body should CHG not be used on? Is it A, perineal area, B, buttocks, C, near the eyes, or D, skin folds, or all of the above? I don't have an all of the above here. C, near the eyes, Valerie, that is absolutely correct. It can be used in the perineal area. That 1 million baths that was done in that very large study cleaned the perineum, and they also did not use any form of tap water on the patient. And so I included that bathing process in here, so you'll have that on your slides as a part of it. So remember, my child, only dead fish go with the flow. So if you're not following that level, and that is high level of science, then you need to be looking at changing that behavior. All right, what else? Disinfecting the hub. The level of evidence is considered moderate before accessing the catheter cup. Needleless connectors or injection ports need to be visibly mechanical friction. You can do it with alcohol or chlorhexidine, minimum of 5 seconds. And by the way, if you use the chlorhexidine combined with alcohol, that has more residual activity that will hang around. And it's important to measure compliance of this practice. And I will tell you, on the disinfection of the hub, they classify this as a unresolved issue, not to use it. No, there is still good science on utilization. What they consider an unresolved issue in the new guidelines is whether mechanical disinfection needs to occur if I'm using passive disinfection. That's what they don't have data on. But we have good meta-analysis comparing manual disinfection to the antiseptic barrier cap. And you can see here, this is a forest plot. This is your confidence interval. Everything favors the routine alcohol or CHG prep. And in this study, it was mostly alcohol. And over here, phase the passive disinfection. So are any of you using passive disinfection caps? So that would be like your swab cap or your Curos cap. Yes. I'm hoping to see a lot of yeses here. We use swab caps. Awesome. Yes. That is great. That really helps. All right. When are your needleless connectors being replaced? Are they being replaced with the tubing change as needed if occluded, visible blood, or debris is seen prior to drawing blood cultures every 96 hours if not being accessed? Or other? Check all of the above. Choose all that apply. Well, you can't really, because you probably can't type that. So pretty much all of those come into play when they should be. But I don't know if you guys have been access to this research. I did include it. It did show up in the new guidelines. It didn't show up in INS because of their publication cycle, the Infusion Nursing Society. Routine administration sets can be changed at an interval up to 7 days, and that includes the needleless connector. Did any of you know this? So this will reduce a significant burden on your main IVs. This does not include blood products, or lipid formations. And they don't, we don't have optimal replacement for intermediate. Change locks Q7, great. Change them with the fluid administration sets. Include that all together. No, INS is not about changing at 7 days because they missed the window. They were already in publication cycle when this very large study was published in Lancet. But what is, it is in the bloodstream guidelines from Shea. that the link was shared so that you have it. We're going to make sure you have all the resources. Excuse me. Oh, Lord. Sorry about that. My Rifampin, so the two that work are the chlorhexidine based and the myocycline rifampin impregnated catheters. And when should they be used? They should be used if you are still having infection rates. So you guys shouldn't be using this at all because it would be a waste of money. So hopefully none of your facilities are using impregnated central line catheters. And I would say you shouldn't be using the antimicrobial PICC catheters either. They should only be used again if you have a problem with infection, that regular infection prevention strategies of the bundles have not shown to have an impact. And so I'm going to say again, when would now be a good time to do this? It's not enough for us to do our best. We've got to know what to do and then do our best. So again, one of my favorite quotes, forbid yourself to be deterred by poor odds just because your mind is calculated that the opposition is too great. If it was easy, everyone would be in healthcare, and they're not, right? So what I'd like to do is stop my sharing so we can get the Brady Bunch pictures here. Feel free to turn on your camera so I can meet you. And open your microphone if you have a question. This was a lot of information, guys, that we packed in here. We'll be going over some of it again in the workshops and when I do rounding as well. Valerie, do you have a question? You can also put it in the chat box if you don't want to speak up into the microphone.
Can you hear me now?
I gotcha.
Okay, so on the IV tubing changes every 7 days, we're talking about hooked up, not intermittent, not being detached for things, correct?
Yes.
Like continuously running.
Yes.
So, because yeah, I think we change every 96 hours normally, but
right.
For our intermittent, I'm disconnecting, we're changing daily.
Actually, most places for intermittent are because of the fact that it's open, you know, because you're attaching, you're closing, you're opening. And so, but I'm talking what you used to do at 96 hours, the science is now supporting moving it to 7 days. So one, you can save money and also save the staff time.
Okay.
And you guys will be early adopters.
I just gotta get my pharmacist on board with, I think that's her policy, so.
Well, basically take the data of the guidelines that just came out. And then I have the reference to the Lancet study.
Check.
I appreciate that information as well. So thank you.
Oh, you're welcome. Yeah, I'm working to try and spread that as fast as I can because anything that can reduce nursing workload and not cause harm is what we want to share. So I will tell you, what I see, dressing disruption and the bathing is where I see a lot of practice variation for nurses. And now if you've got the disinfection caps and you've audited that, and do you just put them on central lines or do you put them on all lines? Who's using the disinfection caps?
We put them on all lines.
Good. That's the best way to do it. Leah, thank you. That's the best way to do it. And do you audit that every once in a while to just make sure the practice is good? Since implementation? No. So that's an area to do a spot check on, guys, because it's behavior that can drift, just like the bathing behavior drifts all the time. and the dressing components. But I would really think about, especially with your slightly longer utilization, besides implementing some of those strategies to manage whether the catheter is appropriate or not, I would really think about adding to my dressing kit something that makes it more adhesive. But those are the areas that I see across the board that are challenging.
This is Amber. I have
Anybody
a
else have
question for
questions?
you,
Oh, go ahead, sorry.
I was just going to ask if you have any suggestions on like annual competencies that related to lines or dressing changes. If you have any suggestions that hospitals need to include in their competencies.
Well, I would tell you most hospitals have central line dressing change as a competency because it's a physical thing. You know, I don't necessarily need a competency on the caps and things like that, but the dressing change is really important.
Great.
And
Thank you.
then I do observations on the bathing. Because one of the things that I found as I've crossed the country is everybody starts the CHG bathing here instead of at the jawline. And if you have an IJ, you're missing an entire opportunity of cleansing. Any other questions, guys? Hopefully you found this helpful.
Kathleen, do you have any, let's call it scripting to use with the providers to poke and prod them to get them to take these lines out sooner than later?
Basically, I go back to why it was inserted.
Okay.
So I'll ask the question, and this is a great question. I'll ask, can you help me understand why the line was inserted? And if they tell me because of this and this, well, those indications no longer exist.
Okay.
And we can put an ultrasound, if you're concerned, we can put a midline or an ultrasound guided peripheral in.
Because I think often we hear, well, we might need it.
Oh, so by the way, the just in case, thank you for bringing that up, Valerie. There is literally a make it work tip sheet in the AHRQ overcoming challenges that says just in case, and it has scripting language in it.
Okay.
So if you have trouble finding it, let me know. I can hunt it. I can go in there real quick and grab it and send it to Dana and Dana or Amber, and they can send it out. Okay. I think that's it. We are at time or a minute over. And I'm looking
Awesome.
forward to meeting some of you in person through our workshop.
Awesome. Yes, thank you. If you guys have not gotten signed up and you're interested, holler at Amber and I will let you know what's available still for spots for those hands-on sessions. They're going to be really useful. So otherwise, thanks everybody. Have a great rest of your day. Thanks, Kathleen. Always great information. You make me feel so ill-equipped. So much to learn. It's awesome. So anyway, thanks everybody. Have a good rest of your day. These recordings will come out on the website once we get all our ducks in a row. So be watching for that. We'll let you know. So
And
thanks
they'll come
everybody. Have a
out-
good day.
And Dana, they'll come out with the PDF too.
Yes, I have slides. So we'll have slides and then the
Great.
recording. Yep.
Great, thank you. All right.
Thanks.